Hi, I'm Alex Tomas, Sales Manager for Drugstore News, and I'll be moderating today's webinar presented by LexisNexis Risk Solutions. The title of today's webinar is Retail Pharmacy, the Year in Review and Planning for 2021. Before we begin, I just want to go over a few housekeeping notes. First, this presentation is protected by the United States and international copyright laws. Reproduction, distribution, display, and use of the presentation without written permission of Ensemble IQ, Drugstore News, or LexisNexis is prohibited. Now, a few things about the audio. The audio is streamed through your device or your computer through your audio system, so make sure your speakers are unmuted and you have your volume up for a better user experience. We will be doing a Q&A at the end of this presentation. You can submit questions at any time. Use the question box on the left-hand side directly underneath the panelist video feed. If you have, if you'd like to watch this after or share this webinar with any of your colleagues, it will be available on demand. It'll be posted in a few hours on drugstorenews.com. Now let's begin. Okay, so this webinar, today's webinar, will focus on the LexisNexis industry-wide year in review survey that highlights COVID's impact on pharmacy. Please join me in welcoming Jill Regan, Director of Relationship Management, John Heller, Director of Pharmacy Sales, and Richard Marino, Senior Director, Solutions Consultants. Our speakers will present actionable steps pharmacies can take to better prepare for the effects of legislation and the ongoing pandemic as it relates to pharmacy operations and patient engagement. So let's kick off the presentation with Jill. Jill, are you ready?
Yes, thanks, Alex.
Got it.
All right, good afternoon, everyone, and thank you for that introduction, Alex. We truly appreciate the opportunity to provide you with an update on the year in review 2020. We all know what a wonderful and fun year it's been, and more importantly, a challenging year. So I have with me today, as Alex mentioned, my colleagues John Heller and Rich Marino. My name's Jill Regan. I am a pharmacist. I've been in the pharmacy industry for over 25 years. I've served in many capacities in my 25-year history as a district manager. I've also worked in pharmacy operations. I've also worked in auditing. So I know a lot about what you're experiencing, but this year's really presented some challenges for us in the pharmacy industry. As Alex mentioned, our learning objectives today are to review the results of the survey that we rolled out earlier this year, to take a look at how COVID-19 impacted pharmacy operations, to cover the state license renewals and prescribing rules that have been impacted significantly as a result of the pandemic, and finally, to share some ideas on how pharmacies can implement some solutions to help mitigate these impacts right there within your pharmacy workflow. So let's go ahead and get started. Now, I'm here. I know this is not news to all of us, but for sake of reference, let's look at where we've come and where we are today. So first, we heard about COVID back in December of 2019 with some reports of pneumonia with unknown causes in Wuhan City. And then in January of this year, we had our first case of COVID. And then in January 31st of this year, HHS declared a public health emergency. Then we rolled into an emergency use authorization by the FDA, granting the CDC the ability to develop COVID tests. We've also had the Stafford Act that was rolled out in March. We had the pandemic declared by President Trump in March as well. In fact, Friday the 13th of March, who can forget that day? We've also had three major relief packages that totaled more than $2.8 trillion in funds passed between March and April timeframe. And then in late March, President Trump signed into law the CARES Act. So in addition to these relief packages, the CARES Act really did expand the uninsurance benefits and relief funds for individuals. The CARES Act had several health provisions associated with it, including addressing personal protective equipment shortages, coverage of diagnostic testing, support for healthcare providers, and then most importantly, and what we're seeing significant increase in, is in telehealth services. Telehealth service access was expanded, and also we saw strengthening related usage of Medicare and Medicaid provisions. So if we jump ahead into November, and what we're all waiting on as of today is the vaccines, right? In November, we had Pfizer and Moderna announced their vaccine trials were over 90% effective. And then we also have AstraZeneca and other manufacturers who have also announced their vaccine. So where are we today? Well, the numbers are staggering, right? Today, these numbers continue to grow with 13.3 million people infected with COVID-19 and greater than 267,000 deaths. In fact, globally, we have over 1.5 million lives that have been lost due to COVID. So as part of our survey, we had asked some questions related to COVID vaccine. And by now, and we're still waiting on the results of the emergency use authorization approvals, but by now you're all aware and probably very heavily involved in the COVID vaccine race, right? So these are the three manufacturers of the vaccine. We have Pfizer, we have Moderna, as I mentioned, we have AstraZeneca, all showing greater than 94% effectiveness. Moderna announced their vaccine was 94%, and then Pfizer came back and said that their vaccine was 95% effective. These are the numbers of the doses that the top three COVID vaccine candidates have pre-ordered by country. We also know that Pfizer has already started delivering vaccine in Europe. So you can see to date the number of vaccines that have been ordered by country. But let's not forget that the Health and Human Services efforts here in the United States, our efforts are to ensure that every American has access to the vaccine. So on September 23rd, HHS issued guidance indicating that state licensed pharmacists, regardless of any current state level restrictions, can order and administer any FDA-approved COVID-19 vaccine to any patient over the age of 3. This guidance also indicated that pharmacy technicians could administer the vaccine, of course, under the direct supervision of a pharmacist. So we are seeing several retailers who are expanding and hiring additional technician staff to assist with the delivery of vaccines. We're also aware that in October, the Trump administration announced a partnership with CVS and Walgreens to ensure the availability and administration of vaccines to the residents of long-term care facilities and nationwide at no cost. And then in November, on November 12th, the partnership was expanded to continue with the government making agreements with many of the large chain pharmacies, in addition to the networks that represent regional chains and independent pharmacies. So this partnership really will cover approximately 60% of the pharmacies in the US. So in addition to CVS Walgreens, you also have other retailers like Rite Aid, Walmart, Kroger, Costco, Publix, Albertsons, Topco, to name a few, as well as your good neighbor pharmacies and your medicine shops who are able to deliver the vaccines. As Alex mentioned, we did roll out a survey here from LexisNexis Risk Solutions in October, and that survey had over 200 approximately 230 pharmacists respond. We're seeing pharmacists from various areas of the industry, not only retailers, but also big box pharmacies. We also are seeing health system pharmacists who responded. And rounding out, we saw about 4% of the pharmacists coming from specialty. So as part of the survey, LexisNexis asked pharmacies whether they had a plan to administer the COVID-19 vaccine once available. And as you can see from the graph on the left, over 60% are planning to administer the vaccine in some capacity. Respondents were also asked, what challenges did you foresee with offering COVID vaccine? And you can see on the right-hand side of the chart there that 82% of pharmacies are concerned about the availability of the vaccine. Of course, we know that the availability of the vaccine may be somewhat limited, but we also saw that 59% were concerned with meeting the demand of the customers, while 56% voiced concern over the tracking of the dosing regimens since the vaccines are given in multiple doses. So this could be of a concern to you as a pharmacist. And how are you going to track that patient who comes in for that first dose and make sure that they do get their second dose to ensure that they are covered and develop an immunity to the virus? We know that the vaccines are given either 21 or 28 days apart. So how are you going to track that on your end? As you can see, that was the concern with many of our respondents. In addition, a concern might be how to reach out to those patients who are at risk, how to bring them into the pharmacy, or how to ensure that they are getting their vaccine, how to prioritize those most at risk. So you can see that in addition to the concerns that were voiced here, you may have some additional concerns on your end. Almost 90% of our respondents don't use a vendor to assist with patient immunization tracking or outreach. So this might be something that you do want to consider, right? How do you reach out to those patients who are at most at risk? Are you using a vendor to assist you with that? Or do you have an in-house solution? And then greater than 60% of our respondents did anticipate, obviously, that there would be some challenges overall. Another area, as I mentioned, with the pandemic was in the expansion of telehealth services. So this saw one of the most dramatic shifts in the delivery of care with telehealth services. The nationwide expansion of telehealth services has really helped providers and practitioners, as well as patients, maintain that continuity of care. Obviously, social distancing, telehealth is able to support that, and communities have really benefited from this vital service while reducing the potential care gaps and limiting patients' exposure to COVID-19. So within the first few weeks of the pandemic in early March, once the pandemic was declared, telehealth transactions really did increase by over 1,000%. And then when you take a look at the numbers of the week of April 19th of 2020 and compare that week to April of 19th of 2019, some states were really seeing significant increase in telehealth services. States like New York, New Jersey, Connecticut, and Maryland saw a 16,000 to 31,000% increase in telehealth services. So as you all are aware, the CARES Act is possibly going to be expiring soon. But we are anticipating over 1 billion transactions via telehealth by the end of the year. So just a few short weeks away. Now, how does that affect pharmacy? So the use of telehealth in pharmacies grown exponentially as well. Not only are we seeing the adoption of telehealth and telepharmacy services by boards, but we're also seeing state boards that are lessening the current restrictions to promote the adoption within their state. So take, for example, Louisiana, who previously required that a telepharmacy location needed to be at least 20 miles from a nearby pharmacy. So recently with the pandemic, Louisiana has lessened that restriction and has reduced down to 15 miles. Some examples of telepharmacy services include remote dispensing. So there are pharmacies who may be having technicians or pharmacists validate and QA a prescription right from their home. And then there's also pharmacies who are overwhelmingly providing MTM services via telehealth. Surprisingly, MTM was 36.1% of the respondents from our survey are using telehealth services in their pharmacies for MTM. Patient counseling came in at 20%, and then, like I mentioned, remote order entry came in at 22%. Another area where you can focus in your organization, or maybe you already do, is in looking at those patients who might need to have patient outreach. Maybe those patients are more isolated as a result of COVID-19. Maybe they're living by themselves with no nearby family member or friend to assist and help ensure that they are taking their medications properly. So we all know that it is a challenge today. Pharmacies are very busy. So obviously the bench pharmacists might not be able to just drop everything they're doing and provide telepharmacy visits to check in on Mrs. Jones, who they know is socially isolated. But this might be an opportunity to explore having a separate use or a separate team of pharmacists who are able to provide this type of service moving into 2021 to ensure patients and their medications are being taken properly. So now I'm going to move in, and I think we have a polling question coming up here. So which of the following do you find to be the leading barrier slowing the adoption of telepharmacy in the pharmacy industry? I'll give you a minute to go ahead and let me know your thoughts. Is it state regulation, lack of supportive organization, funding of required technology, or possibly patient acceptance? Well, looks like the survey results are in, and it looks like most of you said the technology, right? So that is a challenge, right? As I mentioned, not only with pharmacists, right? They're working the bench. Having the technology available, but maybe that technology isn't quite implemented in your organization or in your pharmacy. It is critical that the application or the technology that is used is HIPAA compliant. So just picking up your iPhone and doing FaceTime with your patients might not be the right method for delivery of telepharmacy services. So that could significantly be a challenge for you in the retail or healthcare setting. All right. You had also said that the state regulations, right? So understanding that came in second at 30%. State regulations are changing, right? So you do need to understand what your regulations are for the particular states that you operate in. Are services permitted? And if so, what are the regulations for providing telepharmacy visits? So let's go ahead and talk about the prescribing rules and how they've changed as a result of COVID-19. So we've seen some significant changes early on in the pandemic, mainly around the extension of the renewal deadlines. I know here for me in Illinois, my license was ready to expire in March, and our governor had an emergency order that extended renewals out until September, and has subsequently also extended even further. So we've seen the extension of prescriber renewal deadlines, as well as pharmacists and pharmacy technician deadlines. Some states have extended that renewal to a particular date. Maybe it was September 30th, maybe it's December 31st. Every state had their own emergency order issued. So that can be something that is very challenging to keep up with. We also have seen states that have extended the extension renewals until the end of the pandemic. So at this point, we don't quite know when the end of the pandemic will be announced. So it is critical that you do stay up to date with your particular state's rules and regulations, especially as it relates to prescriber rules as well as renewals. We also saw and are continuing to see states permitting refill without authorization by the prescriber. So in some scenarios, some states expanded their refill authorization without approval from the prescriber for drugs in the same class. We've also seen states that have allowed a refill renewal on a C2 for up to 30 days in certain circumstances. States like Arkansas and Mississippi authorized a one-time refill without prescriber authorization. We've also seen states allow for 30 days dispensing on chronic medications without prescriber authorization. And then there are states who allowed for 60 or even up to 90-day dispensing without reaching out and getting prescriber authorization. We've also seen states where the pharmacist was able to authorize therapeutic substitution. So this could be an example where, as long as the drug was exchanged in the same FDA drug classification. We've also seen states that have allowed therapeutic substitution if the drug was not available and a therapeutic equivalent existed. So this could ensure that patients continued to receive their chronic medications as long as a drug was in the same therapeutic class without prescriber approval. We've also seen some states that allowed for substitution if a drug was in short supply or there was a critical shortage. So again, these were things that we have seen throughout the pandemic. You definitely want to check with your particular state and where you practice to ensure that you have the most up-to-date information and that you're practicing against the current rules that are ever-changing and constantly being reviewed and extended. One of the most critical areas that we have seen is in the DEA emergency exception. So on March 23rd, the DEA indicated an emergency exception stating that DEA registered practitioners are not required to obtain additional registration with the DEA in the additional states where the dispensing, including prescribing and administering, occurs for the duration of the public health emergency. So long as the practitioner is authorized to dispense controlled substances, both by the state in which the practitioner is registered and the state in which the dispensing occurs through telemedicine. So this exception will continue throughout the duration of the public health emergency. And as I mentioned, many states extended their renewals. We also saw states that extended their CE requirements as part of the renewal process. So again, I can't stress enough the importance of double checking with your particular state's licensing board to make sure you have the latest information. One of the final areas that we focused on during our survey was around the impact of COVID in patients receiving prescriptions through mail order versus their retail pharmacy. And interestingly, most pharmacies offering mail order didn't really see an increase in that channel during the pandemic. And Rich will get into that a little bit more in his portion of today's presentation, where most patients do live within 5 miles of a pharmacy. And we are the most trusted profession So they do trust us and want to come see us. But interestingly, from the results, greater than 85% of our respondents do anticipate mail order prescription fraud-related activity. Specifically, not being able to properly validate the identities of both patients as well as prescribers. Now, as I mentioned, I've got a lot of experience, 25 years in pharmacy, and I know that we're always on the edge to ensure that we don't have fraudulent prescriptions being either phoned in, faxed in, or sent into us, brought in. So that is a concern to begin with. As we all know that during COVID, we've seen an increase in patient identity theft. We've seen an increase in scams. So really ensuring that you have the right patient information to mitigate any potential fraud, that you have the right prescriber information. John will get into how data changes quickly. So it's critical that you do have up-to-date information on both your patients as well as your prescribers to mitigate any potential fraud as best you can. Now, we do know that as part of COVID, patients' mobility did increase either because of loss of a job, so they had lost their home, or they might have had to move in with a family member or vice versa. So we do see that patients' demographics, including address, phone information, does change and has changed even more as a result of COVID. So this presents another challenge for those pharmacies who either mail their prescriptions to patients or do some type of delivery service to ensure that patient is getting their medication. So it's critical that you do have the right patient information, the right patient address to mitigate any potential fraud and to ensure the patient gets the medication. So with that, I'm going to jump and turn things over to John. And you can see here that COVID really has had a major impact on regulations, not to mention the delivery of care through telehealth and telemedicine. Our landscape is continuing to change. Healthcare is no longer familiar to us. For those who've been in the industry for over 25 years, there's a new norm, as we mentioned. So you really need to take a look and plan ahead. And John's going to give you some ideas on what you can do to help mitigate this ever-changing landscape. So with that, I'm going to go ahead and turn things over to John. I look forward to your questions, and thanks for your time.
Jill, thank you very much. I appreciate it. And I want to apologize. I'm not on video. It's not that I'm having a bad hair day. I'm just having some connectivity issues. So again, thank you all for joining us today. So as part of our survey, we asked the following question. Do you expect that relaxation of out-of-state prescriber regulations will be rolled back post-COVID-19? And over 50% of the respondents said they don't think they will be, even after everyone gets vaccinated. So even if they are rolled back, it will be late spring, probably, as the vaccine won't widely be available until then. Jill, can you go to the next slide? So whether these regulations are only temporary or become the norm post-COVID-19, the onus still is going to fall on the pharmacist to keep tabs on what type of provider can dispense what specific class of drugs, say in the state of Georgia versus Florida. So with that in mind, it's important to have as accurate data as possible specific to these providers, as their practice address, their phone number, their fax number, and even their license status are likely to change from time to time. So we know this to be true as the LexisNexis provider master file, which we're most known for in retail pharmacy and is largely considered the record of truth, is updated in essentially real time. So what we're able to do is see these updates as soon as they show up in our master file. So for example, across 2.8 million prescribers, what do we see as far as churn? So over a 7-day period, we see about 33,000 changes in primary practice address. We see about 100,000 changes in state license expiration dates and statuses, as well as almost 2,000 changes in phone numbers, and again, in a 7-day period, almost 1,500 fax numbers changing as well. So using inaccurate prescriber data can lead to recoup reimbursements and possibly fines if the prescription dispense was written by a sanctioned or deceased provider, or even if the provider with a revoked DEA license. Joe, can you hit the next slide? Okay, so now it's time for another polling question. The question is, since March of this year, which of the following compliance issues has your organization experienced regarding prescribers? A, confusion on the prescribing activities permitted during the emergency declaration. B, inappropriate third-party rejects. Or C, inappropriate recoupment of reimbursements. Or D, sanctions and or fines. Or E, none of the above. So we'll give you all a minute to respond. All righty, excellent. So the results are in, and not surprisingly, A was the most popular. We're at about 70% for A and about 23% for B. So when we initially did our survey, over actually 78% responded with A. So that's very close to what we're seeing today. All right. Joe, can you go to the next slide? Okay. So when it comes to state-level prescriptive authority, the relaxation of the rules has definitely made it even more challenging as far as keeping up with the rules at the state level. Every state has its own set of rules that can get pretty granular, especially when it comes to mid-level practitioners. For example, in the state of Georgia, a nurse practitioner is not allowed to write for a C2, but just south in the state of Florida they can, but only for a 7-day supply. While in South Carolina, they also can write for a controlled substance but only for 5 days, 5-day supply. So to make things even more complicated, a prescriber may be writing a prescription in the state of Georgia in which they're licensed, but the patient resides across the border in Florida where the dispensing pharmacy is located and where the patient resides, which is going to cause even more confusion. Okay, so there are many pharmacy dispensing systems available, but one of the things that none of them is really able to do is maintain and keep track of pharmacy state-level dispensing rules. So because of that, we built a real-time solution to address this, which we call VerifyRx, which many of the largest retail pharmacy chains use today, as well as specialty pharmacies. We built VerifyRx about 12 years ago, and currently we're seeing about over 10 million prescriptions pass through the VerifyRx solution on a daily basis. So it's gotten very, very popular. VerifyRx leverages our daily updated master file and reviews the various data elements specific to the provider who wrote the prescription and the drug to ensure there are no issues before the prescription walks out the door and the claim is routed to the payer for adjudication. So as of today, we have about 70 real-time validation checks, and many of these were built specifically at the request of one or more of our clients to address specific business cases that they have. VerifyRx edits the claim in real time. So, for example, if the submitted NPI number or DEA number are incorrect or expired, we'll send a message to the pharmacist, or if it's a Medicaid prescription and we know that the provider ID has been sanctioned for that doctor, we'll be able to send a message if that occurs, as well as allow the staff to react to the message in real time. So VerifyRx is a highly customized solution. We allow our clients to basically manage all these validation checks themselves. We give them the opportunity to activate them, deactivate them if an issue arises, as well as running reporting. So it's become very popular, and it's definitely a solution that we want to recommend. So with that, I'm going to hand things off to Rich Marino. And before I do, I want to indicate that, thanks to COVID, millions and millions of U.S. citizens have forgone going for regular checkups as well as more serious medical care for the past 10 months, which is probably going to affect everybody on this call one way or another. So Rich Marino, who's our Senior Director and Solutions Consultant, is going to talk about how our pharmacy clients are able to leverage our data assets to identify those most at risk for falling between the cracks. Rich?
Thanks, John. That was a great introduction, and thank you all for attending our session here today. The topic of our session is 2020 planning, essentially 2020, the year in review, and 2021 planning. And there's no way that story occurs without the discussion on COVID-19. Frankly, it's practically the entire story. So whereas so far my colleagues to date have talked about a lot of the changes to your operations in order to go ahead and operate during this pandemic, I'm going to talk a little bit about the working with the patients, what the impact on that is. Specifically, we're going to start talking a little bit about folks who might be avoiding care, what this pandemic means to them. And then we'll talk about handling the vaccine and preparing to be a center point of patients' actual health and where they go to get it delivered. So let's go ahead and dive into the material. Some of you might have seen some of this research before. The pie chart on the bottom left comes specifically from Kaiser Family Foundation. And what it's telling us is that, and this is from research, probably late summer, early fall, that over half the public has been avoiding care during the course of this pandemic. Now, if you recall earlier in the year, around April and May, there's a lot of facilities that actually shut down, which might have led to this numbers being so significant. But here at LexisNexis, we also keep track of the utilization of care. And we can see despite all settings and all sorts of diagnostic tests being done, the volume is significantly down from the height of May to some things like breast cancer screening being 8% less than what they were accustomed to the year before, through September and October, where you're still seeing a reduction in the 30 to 40% less care being delivered than was in the same time period in 2019. So it's a significant issue, and it's extremely significant if you look at the in the middle, what we have right there is the bar chart. What it's telling you is there's 11% of individuals who are essentially know their healthcare is getting worse, but still are not going in to receive care. So that's a very scary thought, because if we talk about what the United States healthcare system is attempting to do these days, what we're attempting to do is invest in preventative screening and make sure that you don't get sick, especially sick with the chronic conditions, which could lead to deterioration in your health, your outcomes, and your quality of life, and a dramatic escalation in regards to medical costs. To crystallize this problem a little bit more in the forms of COVID-19, we could take a look at some of the research you see here on the left-hand side. Essentially, what this information is telling us is that if you try and look at year 2020, it essentially says that we're about 48.8% of the United States adult population has at least one chronic condition. On my far right-hand side, you can see a variety of those different conditions that just shy of half the population of the United States has at least one of. So when we talk about people who might be at risk for COVID-19, and it's usually the individuals who have chronic conditions, that is about half the population. And if you look in the middle as well, we say additionally members with chronic conditions account for 81% of hospital admissions, 76% of all physician visits, and I'm sure no surprise to all of you on this call today, 91% of all prescriptions filled come from individuals with at least one chronic condition. So it's imperative that we take a look at this for two lenses. One, how can we keep these people healthy during the pandemic where they're inclined to avoid care? And two, how can we make sure that these individuals who are at more risk for COVID are prioritized for being managed and engaged to receive not only the first dosage, but second dosage that it looks like all the vaccines will require. So if I'm painting a little bit of a dark picture, I'm going to finish with this next slide, and then I'll start making it a little more optimistic. On the left side of this equation, if you will, we see COVID impact on socioeconomic status. So we're talking about the non-clinical things which impact an individual's ability to go ahead and take care of their health. And what you can see is that we fully expect, for a lot of the reasons that Jill and John articulated earlier, especially in regards to the CARES Act and unemployment and so forth, we expect that more patients are at risk of not being adherent to their current prescribed medications. Now, this is due to a rise in income insecurity, unemployment, insurance coverage, a lack of stimulus, you name it. There's a variety of conditions by which we believe that people's socioeconomic status broadly is starting to deteriorate a little bit. One thing that we're actually keeping an eye on right now is evictions. If the moratorium on those ceases, we're going to probably see a big escalation on that, and then housing stability could also lead to people's likelihood of being medically adherent. But I'm going to focus now on the right-hand side, because this is where we're going to spend the rest of our conversation. How can we fix this? How can we address this? Well, the good news is that 90% of Americans visit a pharmacy during this time. So earlier, I showed you a pandemic that said 50% of people are avoiding healthcare and office and facility settings. Only 10% of Americans are avoiding pharmacies. And 90% of Americans live within 5 miles of a pharmacy that Jill had alluded to earlier. So what we have here is a real opportunity for pharmacies to take a unique role in delivering care to chronic care populations and start to become that trusted, safe, and convenient location that more and more of individuals' care will be coordinated at. So just as earlier, Jill talked about how telehealth has exploded. They've advanced 10 years in 5 months in the early part of the year as a result of the pandemic. So too can the transformation of pharmacies from being the dispensing location to the central hub of taking care of care. A similar evolution can occur. So now that we've discussed, okay, what the statistics to show the dire situation that we're in, talk a little bit more about now how the pharmacy could go ahead and take advantage of information out there to help facilitate this evolution. So I talked about medication adherence. Now, medication adherence is going to be critical for both of the two bullets that we're really kind of articulating here on this portion of the presentation. And that is, it's critical to not only address the people who will need the vaccination, which is everyone, but those at risk of not taking the second dosage, but also those who are at risk for not following necessary prescriptions today, which will lead to their health being deteriorated. So let's hypothesize right here. You can see 4 individuals, Jen, Manny, Will, and Jack. Clinically, they all look the same. They're all male, they're all 55 years old, they've all been prescribed medications for chronic illness. All right, let's pretend for a moment it's diabetes. And so they're all pretty much the same level. Now, we know that 20 to 30% of prescriptions are never filled, and 50% of medications for chronic disease are not taken as they're prescribed. So the goal is to try and figure out, well, if they all look clinically the same, is there any way with our finite resources to ascertain who is at more risk for not taking these, let's just say it's insulin. You're trending towards type 2 diabetic or something like that. If you're not taking the medications, or the statins, probably more appropriate, my apologies. You're not taking your statin, and it's going to deteriorate with your diabetic condition, go from pre-diabetic to full-on type 2, right? But you're not getting it filled. Well, what are the reasons that might be happening? Now, this is where we believe that social determinants of health, for those of you who are familiar with that buzzword, can play a big role. Because on the last slide, I showed you that they all basically have the same clinical footprint. But if I overlay socioeconomic information, we can see there's vast differences between the status of Jack versus Chen. And there's a whole spectrum there that encompasses that. So when you look at Jack, we've seen with him a significant decrease in income. And we know at LexisNexis with our scientists and clinicians that if you've seen in the last 2 years a significant drop in income, not only does that mean that you're unlikely to be medically adherent, but also makes you a prime candidate for someone who might be readmitted to the hospital. Someone obviously who has minimum banking experience, what you're really looking at there is not so much your estimated income, because people might live beyond their ways and means. But if you look at kind of a banking experience, how invested are they in various instruments? That can really give you a clear picture on whether or not this person has the disposable or planned budget necessary to take care of their care. If we look at Monty and Will, the significant risks with them, or the risks with them, aren't as significant. Whereas Jack needs some financial assistance, Manny probably needs to, transportation to the pharmacy or to be moved to mail order delivery. Again, we look at Will. He's socioeconomically fine situation, other than being socially isolated. So some type of care coordination to make sure that he's following up on medical protocol. Chen, though, primary risk is simply due to his age and condition. So inviting him to participate in a wellness program or our rewards program and make sure that he comes in for a consultation once a quarter for his drug therapy program probably is more than sufficient. Now, that gives us a good understanding of who's at risk for not taking their medications, and specifically those who are already part of our chronic care programs. But there's also the issue of making sure that people come in not only for their first or second dose, and this is where it's sometimes good to utilize analytics such as motivation. So a motivation model was specifically designed to find out who are the people who are unlikely to show up for this preventative care that's necessary, right? There's all sorts of statistics that show that if you catch breast cancer screening, if you do a breast cancer screening, I should say, and you catch, because of the screening, someone at stage 1, there's a 99% chance of them, 99% chance that they'll live beyond the next 5 years. However, if you catch it at stage 4, that drops to about 27%. So doing these screenings is critical to make sure, again, we're preventing these people's health from deteriorating drastically. Now, on the left-hand side are some common research. This was in regards to the flu vaccination. So we have to take a little bit of a leap of faith that some of these elements would be similar for taking the second dosage, if you will, of COVID-19 vaccination. But you look for such things as, how old they are, their education rate, which is a correlation to health literacy. This particular research I cite below showed that people making over $150,000, where there's a significant jump in their motivation to take care of their own care, coming in for second dosage of vaccinations. People who are married or a partnered relationship, internet access. Unemployment shouldn't be that much of a surprise. And what they cite is that over 72% of individuals without health insurance do not get vaccinated. So this is something that we as a community are going to have to target. Health insurance, as it appears, should not be prevent anyone from going ahead and getting disease, but they'll certainly take a lot more coordination and submission, perhaps with the federal government in regards to that. The idea behind this, though, is if you find someone who's unmotivated, you have to understand why they're unmotivated. And just like we saw with Jack and Chen earlier, the idea is if, for instance, they're socially isolated and lacking transportation, and maybe on top of that, they live in an unsafe neighborhood, a simple identification of why they're at risk. So let's say that they're in this category 4, high risk, and it's because of those elements I just told you. Well, picking them up and taking them to the pharmacy or switching to their drugs, if it's feasible, to mail delivery, could really solve the problem of what prevents them from not only maintaining their current medication adherence program, but also that lack of transportation might be the idea now that you can coordinate with in order to get them into the pharmacy for their first and second dosage of COVID-19 vaccination as well. This type of examination of patients and coordination, almost not just the franchise level, but the overall pharmacy, which will allow you to spot these individuals and make sure that they're getting into the pharmacy for the vaccine and remove any barrier which preclude them from doing so. So I've talked a lot about the clinical and socioeconomic side of how you could stratify and prioritize people who might be at risk for not continuing their care, or as well as those who might be at risk for not coming in for the vaccination. I also, once you find and identify these people, it's critical you're able to reach them. So just as we saw some statistics earlier, I think that John shared about the change in pharmacy and provider information, we have a similar story to tell in regards to your patients, right? So this particular slide shows what type of product they typically are on. What you can see is even if they belong to a large corporation, have insurance through them, the first day that that entity has their contact information is already 15 to 20% inaccurate. Obviously, if you're talking about Medicare and then to Medicaid, it gets worse. Anyone who's on a Medicaid product, on the first day their information is shared within the healthcare ecosystem, that contact information is already 40 to 50% wrong. So if you're trying to utilize that to try and get them back in for the second dosage to make sure that they're doing that and you're collecting on those fees, you have a problem. Now, that's how good the quality of the data is on the first day, but we also know that it erodes 3% a month overall. We know this because we keep track of the population of the United States, And what we see traditionally is about 35 million people move annually in the United States. That isn't to say that someone's moving every year and there's 35 million of them. Just on average, there are 35 million Americans who make some form of move. On top of that, there's 1.5 million changes in marital status. There are almost 4 million children being born annually. And there's about 2.7 million people who die annually. You know, in addition to that, there's 21 million employment changes annually in a year. So all these forces could lead to a tremendous amount of change. And what we're saying is, if we want to make sure that people are coming in not only for their first dosage, but that second dosage, it's critical that we monitor and make sure we provide the right information to our pharmacists so they could go ahead and reach these individuals, make sure they're coming in to get the second vaccination, and truly be able to go ahead and handle the COVID-19 crisis. So just to kind of sum up, what can your pharmacy do to prepare for 2021? We believe that compliance mitigation strategy around prescriber licensing verifications. And I think that Jill and John would be happy to speak to that more. You can see that there is a variety of things we believe that patient prescriber data accuracy could assist with. And we believe that utilizing social determinants of health to kind of screen who's likely to be risk for A, not maintaining their current medication protocol, but second, not following through with the second dosage on COVID-19 would be exceptionally useful. And then making sure you have their updated contact information to get them physically back into the pharmacy. And with that, I think we have a few minutes left for questions.
We do. Thank you so much, Rich. That was excellent. We have received a few questions. Let's jump right into them. For the audience, you can submit a question using the Q&A tool directly on the left-hand side below our presenter headshots. So let's take a look at some of the questions that have popped in. Bear with me 1 minute. All right, so let's start with this question here. Okay, how should pharmacies think about using social determinants of health for vaccine outreach? What have been keys to success for using social determinants of health effectively? Can you elaborate on that?
Yeah, I guess I'll take that one. This is Rich. I kind of alluded to it within the presentation, but essentially what you're looking for is the most analytic models that try and go ahead and predict whether or not someone will be medically adherent, is trying to see whether or not they're going to get at least 80% of their scripts filled, right? So that is the first initial useful model. What socioeconomic data does beyond clinical, clinical could look at various profiles and understand people who didn't get their scripts filled and those who did. What you want to do then is also, once you clinically see them, you want to pivot and see, okay, what are the common socioeconomic things that we could spot that a profile for someone who's not taking their medication. The two biggest ones that usually come about, or three biggest ones, I should say. One is obviously economic instability, so there's a problem affording the medication. Two is a lack of transportation or ability to get to the medication, right? And then finally, the third one tends to be something not as obvious, and that's people who live with the elderly. So elderly is defined as someone over the age of 80 years old. And what we've seen with that is if you live with someone over the 80 years old and you have a chronic condition yourself, you tend to prioritize being the caregiver and that person's care. So not only your time and management, but oftentimes your financial resources go to giving that other person the care. It tends to come at the expense of your own care. Now, the good news around medication adherence is if you solve those problems, most people are likely to go ahead and take the medication. It's a bigger issue when we talk about motivation. Now, I use motivation to talk about how you could get someone to come in for that second dosage, which is probably, it's going to be so critical. Motivation was originally designed to figure out whether or not someone's going to come in for a breast cancer or a colorectal cancer screen type of thing. How engaged are they in their own care? But we found it's a tremendous, provides tremendous insight into ascertaining or predicting who is likely to come on in for instance, drug therapy, medication therapy management for a comprehensive medical review. For instance, how motivated, what's preventing them, again, let's take that someone who's socially isolated, lacking transportation, and lives in a dangerous neighborhood. Well, they're likely not to walk to that pharmacy, even if it might be close by. So depending on what is going to be dispensed, can you move that now to set up a mail order or can you arrange for transportation? I believe The auto company Lyft has agreement with Medicaid in 23 states or 27 states to be that non-emergency transportation to get people back and forth. So when it comes to the social determinants of health, just kind of sum up this question, what's incredibly useful is not just predicting who's at risk, but it gives you the insight why they might be at risk. And that why is going to be very useful for pharmacies to figure out, is there a way that I can increase the likelihood of this person maintaining their medication protocol during COVID, during the pandemic, and motivation, how likely is someone coming in for the second vaccine? And if they're at risk, what's driving that risk? Is it something that the pharmacy could handle and overcome to make sure this person winds up being healthy?
Oh, that's perfect. Thank you. I appreciate that. There's another question that came in. Let's send this to Jill. Jill, this question reads, earlier in the presentation, you noted that I believe it was 80% pharmacies anticipate mail order prescription fraud due to the fact that they will not be able to validate identities of patients. What, if any, are some of the ways that pharmacies can combat those potential frauds?
Oh, absolutely. Thanks, Alex. So as I mentioned, and John and Rich both emphasized as well, it's important that you have accurate patient information, accurate patient address, right? Not only because you want to make sure that you're filling the prescription for the right patient, but mainly with mail order, you want to deliver to the right patient. You run the risk that getting that patient their medication in a timely manner, if you don't have the right address, or potentially delivering medication to someone who shouldn't be getting a medication. So definitely having the right patient address and information is critical to mitigate fraud. One area I'd like to mention that I know we really didn't get into is that most mail order pharmacies or retail pharmacies have some type of patient portal. I know that I have right on my iPhone an app that I can access my local pharmacies application, my patient portal. So you want to have some type of authentication, some verification method that validates that that individual coming in through that patient portal is also who they say they are, so that you ensure that you validated that to get that patient the right medication, and you're refilling and mailing out that right information. So a couple different things you can do, not only keep your addresses up to date, because as John mentioned and Rich mentioned, people move around a lot, and even more so with COVID, you want to have your demographic information for your patients updated, and be able to get them the medication at the right location.
Okay, thank you.
Thanks for that.
Yeah, sure. So there's another question. I'm going to send this over to John. I don't want John to feel left out, so let's give John a question too. John, this question reads, with patient and provider data in constant, almost daily flux, aren't we still working with dated information if it's just a batch upload? Could you elaborate on that?
Yeah, sure, certainly. That's a great question. So yeah, as it relates to prescriber data, it does churn, it changes day to day. And the technology that we have here at LexisNexis enables our clients to leverage the continually updating data, right? So they can access our data almost in real time through different technologies like API connectivity. And then again, VerifyRx is another solution to enable the ability to ensure that you can leverage that most up-to-date, most current data relative to a prescriber.
Okay, I appreciate that. Thank you. We're approaching that hour mark, so we're going to have to wrap this up. But I do want to thank everyone for joining us today. And a special thank you to LexisNexis Risk Solutions and our speakers, Jill, John, and Rich, for sharing these insights with us. If you would like to view this webinar again or share it with your colleagues, it will be available on demand on drugstorenews.com shortly. It'll be right-hand side underneath our webinar tab. Everyone have a wonderful and safe holiday season. We look forward to seeing you here again at a future webinar. Be well, and thanks again.